directed therapy, is it still a practical concept? I'd like to walk you through this. Here are my disclosures. If we take the case of Mr. Mr. HB is hypertensive. Maybe we'll have to discuss the MAP target. Is that a lung resection? Is that high risk for ARDS, high risk for right ventricular failure through acute pulmonary hypertension, at risk for nosocomial pneumonia with the risk of MDR bacteria? His Q-SOFA is definitely over 2 with suspected sepsis.
We don't have your slide.
Sorry, let me get back to that. So, desktop. How about now?
Perfect. Yeah.
Okay, those were my disclosures, and as we said, so Q-SOFA is over 2 with a suspected sepsis. His MAP is very, very deeply under 65, probable shock with evidence of hyperperfusion. His chest X-ray shows a focus of infection, and the most conservative assessment of his SOFA score is over 6, so we probably have unresuscitated septic shock. EGDT, the underlying postulate of EGDT was that septic shock is mainly a problem of oxygen consumption, oxygen delivery, and that central venous saturation in oxygen reflects that inadequate delivery to oxygen consumption. And inadequate delivery would be due to inadequate oxygenation, inadequate transporter, hemoglobin, inadequate mostly cardiac output. And therapeutically, that should be addressed by oxygenation, transfusion, fluids, pressors, and inotropes. So that was the postulate. And all of those aspects were addressed in the seminal study by Emmanuel Rivers, which managed septic shock patients, extremely ill septic shock patients, presenting straight to the emergency department, where they had a central venous catheter with continuous SpVO2 measurement. And they were managed by filling titrated to central venous pressure, followed by ventral pressors if that was not enough to reach the MAP target. And the ultimate target was central venous oxygen saturation, which would be the judge if therapy had to go to transfusion or had to go to administration of inotropes. And in the end was the general arbiter if a patient needed oxygen consumption to be brought down by sedation, intubation, eventual muscle paralysis. This management algorithm actually allowed to bring down an extremely high mortality rate at the time with these very ill patients in the emergency department with 46% mortality, bringing it down to 30% mortality. And that shaped much of the following years of intensive care in septic shock. 10 years later, a trio of randomized control studies addressed the comparison between EGDT, a Rivers-like EGDT, compared to what was at the time, what had become standard care in septic shock patients. This trio were the ARISE study, the PROMISE study, the PROCESS study, and to make things short, none found a significant difference in survival between what had become at the time usual care and EGDT treatment of sepsis. So at the time, this seemed like it would be the end for EGDT, maybe not so fast. When looking at these different studies compared with EGDT, one of the main differences was that EGDT really was as soon as patients were presented to the emergency department, so we're in a 1 to 1.5 hour time frame, and these patients were completely unresuscitated when they were randomized. They had not received any fluids at all, and all the fluids were administered according to the EGDT protocol. In the trio of studies, PROCESS, ARISE, and PROMISE, patients were not managed that early. They were in a 3-hour time frame. And half of the fluids that were administered in the entire study, 6-hour time frame of the study, were administered pre-randomization, pre-protocol. So both groups actually received up to around median of 2 liters of fluids before being compared between EGDT and usual care. So when you look at these studies, here looking at the lactate and the SCVO2 of these patients, EGDT were very ill, completely unresuscitated, with very high lactate and very low SCVO2, compared with Process, Arise, and Promise, which had received, these patients again had received close to 2 liters before being randomized, and maybe therefore had lower lactate and were in a normal range of SCVO2 median. There were about 20% of patients who still had lower SCVO2. And so there was not much room for SCVO2 based improvement in these patients. Doesn't allow to conclude much. So when we look at EGD goals, there may be room for individualization of these goals. First of all, CVP has over the years been replaced by fluid responsiveness. If you look at a post hoc study, a recent post hoc study of the Andromeda shock study, we'll get back to that. But this is just looking at septic shock patients, the subgroup of patients who were fluid responsive after also receiving pre-randomization 2 liters of fluids. And here, the fluid responsive patients start off being completely fluid responsive, and as soon as 2 hours, there's a dramatic decrease in fluid responsiveness. And when you compare these patients receiving, withholding fluids according to responsiveness, and the patients who actually didn't receive any fluids because they started off fluid non-responsive, there's no difference in outcomes. So it's actually quite safe to withhold fluids in septic shock patients who do not seem to have a predicted benefit from it according to fluid responsiveness. Concerning MAP, the sepsis PAM study comparing low versus high MAP targets, which were supposedly 65 to 80, actually practically were more 65, 70 to 80, 85. There was no difference in survival. However, in the subgroup of hypertensive patients, there were better renal outcomes. Again, there's room for individualization, even of the MAP target. And concerning the TRIS study of hemoglobin low versus high thresholds, again, the true thresholds were not the 7 to 9, but more between 7 and 8.5 to 9, between 9 and 10. Again, there was no difference in survival, but the threshold may be somewhere between 7 and 8.5 gram per deciliter in septic shock patients with, again, some room for individualization. Concerning the ultimate goal, which was SCVO2 in the Rivers study, as soon as a few years after Rivers, Jones in the JAMA published SCVO2 compared to lactate clearance. And lactate clearance was an as efficient ultimate goal for septic shock resuscitation as was SCVO2, with identical survival rates when lactate clearance was used to ultimately guide the resuscitation compared to SCVO2. So lactate seems to be a as valid goal, as especially an arbiter of the resuscitation, as would be SCVO2. The more recent Andromeda shock study compared lactate clearance, because that had been shown by the Jones study, with capillary refill time. So the ultimate goals to be attained were judged by either lactate clearance, decrease of lactate over resuscitation, or shortening of the capillary refill time to normal values under 2 seconds. And with, again, a fluid responsiveness and other intermediate goals. There was no difference in survival, although it wasn't significant, although there's a huge debate concerning the statistical analysis, which deemed that this was not significant because the difference was actually quite impressive of 8%. And there were better outcomes in the CRT-driven group for the lesser severe patients. So again, there is room for individualization of targets according to population type in septic shock. One of the more intriguing goals that can be used in the resuscitation of septic shock is the venous to arterial difference in NCO2 partial pressures. This can be considered, if you want to sum it up as simply as possible, as an index which can judge the adequacy of a given cardiac output to a macro and microcirculatory situation. Is there enough cardiac output to wash out CO2 from the tissues, either globally or locally, in different circulations, macrocirculation and also microcirculation? When the cardiac output is not sufficient, this gradient increases to over 6 millimeters of mercury. So from the first EGDT Rivers algorithm, there may possibly be a road to go to more complex algorithms, which obviously cannot address every single situation, but are physiological guides and tools to resuscitate patients. This is one such proposed algorithm from Maurizio Cecconi, actually inspired by Benoit Vallet. They proposed this kind of algorithm together with lactate and capillary refill time as triggers. Much easier to use than central venous oxygenation, doesn't require the patient to have the central line in yet. When that central line is put in, SCVO2 will arbitrate between being low and asking the questions of enough hemoglobin, enough oxygenation, or enough fluids, if the patient is fluid responsiveness or not. Or if that SCVO normal, asking the question whether there is a difference, an increase in venous to arterial CO2, which may unmask residual requirement for either fluid responsiveness or requiring an increase in cardiac output, cardiac index, eventually the use of inotropes or not. So these seem complex, but these are all tools which can be used in the resuscitation of EGDT.
You're on mute.
We don't have any questions from the audience, but any comments from you, Marvin, or from Julien?
Shall I go first? Okay. Yeah,
yes.
No, I very much like and agree with Eric's talk. Again, my message is going to be individualized to the patient. So therefore, we you know, the crucial thing is not to adopt one size fits all, but tailor the physiology and the pharmacology appropriate to that patient, look at the response and then react accordingly. You know, my worry is we adopt brainstem medicine and we don't engage the brain.
Yes, but I found that people are pretty hard with reverse study because that was a very nice model, a very nice direction to manage early the patient. Do you think that all should be in the garbage now? And
oh well, no, I think we've learned that his targets are perhaps not what we would go for now. But I think the philosophy, you know, you get a sick patient in, try and optimize them. You don't want to overdo it, but you don't want to leave the patient under resuscitated. So I think the concept of what he was trying to promote, I think, is 100% appropriate. You know, the balance or the challenges, which are the best targets to aim for. And I think, you know, he was a surgeon by background, therefore everything was fairly rigid. Reach this number, and I think we can hopefully, as I think Eric was suggesting, be a bit more flexible in, you know, tailoring our treatment to the patient in front of us.
Right. And you, Julian, do you still use oligotherapy or something approaching? Because I understand what is personalized medicine, but at 3 o'clock in the morning, during the night, sometimes it's difficult to have all these variables. So what is your feeling, Julien?
I agree with the tailored approach. I think that it's very appealing, very physiologic. The thing is the way you organize your endpoints and the way you organize your variables. Do you begin with perfusion mismatch? Do you begin with fluid responsiveness? What is the first trigger, and how do you organize your therapeutic algorithm? Because it really depends on the major variable you want to optimize. Is it oxygen delivery? Is it CO2 gap? And you see many different algorithms, each of them using the same, for instance, fluid responsiveness and things like this, but they are organized differently. And I'm not sure what is the best way to organize your therapeutic algorithm. I still don't know.
And Eric, what is your conclusion?
Yes, I've a few words on that. Is exactly that. There's no magic algorithm. I think River's work was incredible because it made us think that way. The biggest danger is that we have considered goal-directed to be goal normalization. I think that's very dangerous to try consistently with every goal and every intermediate goal in a patient with septic shock to aim for goal normalization. And that's what led in the River study to huge amounts of transfusion, a huge overuse of inotropes. So if we can just scale back from that, and also if we, as you were saying, Julien, that there's probably not a single magic algorithm, but that all of these goals are tools to be used with each patient, and all these goals should be individualized. So yes, definitely my take-home messages, if I have some, would be here if I'm sharing. Let me just share that. Are you seeing the slide?
Yep.
Yeah.
So my take-home messages would be that the strict rivers like EGDT is no longer really practical. And I would replace that by early individualized, extended goal-oriented titration. That was what Mervyn was also talking about, titrating these therapies. We have to recognize there's no longer a single goal, neither SCVO2 nor lactate clearance to rule them all, to be a little bit Tolkien-esque. And goals should be individualized to the patient's history. Does he have heart failure? Is he hypertensive with a different MAP target? Is the patient at risk for ARDS, where we will be extremely careful with the fluid loading? Is he at risk for right ventricular failure, where that will be even more of a preoccupation? And these goals should be extended. We should extend these goals to other goals that explore local perfusion, like CRT, or even microcirculation in some cases of the arteriovenous PCO2 gap increase. One has to consider goal limitations in gray zones. None of these goals are black and white in some of their intermediate values. And I think the philosophy should be to aim towards goals rather than goal normalization at all costs. And this implies constantly titrating and reassessing the therapies using these goals.
Okay, thank you. We have comment coming from Africa, where they say that in the tertiary world they don't have monitoring and they can't individualize. But I don't fully agree, because the capillary refilling time can be done everywhere in the world very easily, and that's just the opposite. You can follow your patient with this tool, which is free and very convenient for everybody everywhere in the world. So that's a suggestion.